Assalamu alaikum everyone. Welcome to the neurosurgical case room. Am I audible?
Walaikum salam, yes, audible.
Okay. Dr. Itzas, are you with us?
Walaikum salam, yes, I am here.
Okay. So I have started the recording and we have already started the live streaming. So you can take over from here. I'm muting myself and I'm requesting everyone else to mute themselves as well. But I'm here for the moderation if there is needed. I'm muting myself and you are the co-host now.
Assalamu alaikum and good evening, everyone. So, after 2 days of holidays, we are again with you people. I think you don't have the holidays, but we have. Those who are going to appear in exam, they don't have any kind of holidays, but we have. So, today we will try to complete the spinal tuberculosis and Pott's disease. Let's start. What we want to say, actually, there's a lot of controversies in this topic, and there is a lot of, to some extent, there is a limited some guidelines regarding the management there are, and according to the approaches, surgical approaches, there are some controversies. So we will try our best to be in midland and the middle area, but the posterior approaches in favor of posterior approaches, those who are in favor of posterior approaches, and those who are in favor of anterior approaches. So we will try to be in the middle of both of them so that we can, when we say that when there is a shift toward the anterior side, we'll go to the anterior side. When there will be a shift to the posterior side, then we'll shift to the posterior side. So actually, when we say the spinal tuberculosis and the Pott's disease, it have a lot of divisions over there. Early infection versus late infection, a pattern of involvement, what is there? It's the anterior involvement pattern, it's posterior involvement pattern, it's a central involvement pattern, synovial joint pattern. What is the pathophysiology behind that, and what are the factors which are important? And what is the classification different? How the instability is there, how to define instability score, and then the management options, conservative versus the, you can say, the surgical management. Basically, when we say the early infection and versus late infection, the early infection, actually not early, any kind of infection that is related to the tuberculosis. The tuberculosis is spine infection. It starts from the, you can say, the end plates and the metaphysis of the vertebral body. Either it's the early and the late. Late will be converted from, that is early infection, or acute will be later on at chronic infection. So that's why when it starts from the end plates, epiphyseal end plates. And then it traverses through with the help of anterior longitudinal ligament. When this infection spreads more, then with the help of anterior longitudinal ligament, actually, it leads to the multi-level involvement. Multi-level involvement will be because of the two things. One, either due to anterior longitudinal ligament. When you will see the images, and many of you people have gone through the images, you have seen the thick enhancement fold over there and thick enhancement pattern over there at the level of anterior longitudinal ligament. With the help of that one, there is a multi-level involvement. Why? Why there is a multi-level involvement? Because of the anterior longitudinal ligament. Anyone? Yes, please, anyone? Anyone want to comment because of this one, that why only anterior longitudinal ligament? Though there is later on, there is a posterior involvement, and with the help of posteriorly it spreads, but most likely the anterior, because the anterior end plates, they are more vascular. Arterial arcades are there. When we see the bony anatomy and vascular anatomy of the spine, actually, the vascular anatomy is more as to the level of anterior end plates, and they form the arterial arcade over there. And with the help of that one, it is very related and attached to the anterior longitudinal ligament. That's why it is pressed with the help of this way. When we see the early infection, it is passed through, but there are a lot of characteristics of this one. Escape lesion or non-contiguous segments will be 15%. Paraspinal formation could be up to the 50%. Usually, anterior end can be quite large, much more common in tuberculosis than pyogenic infection when we see in the early infection. Initially, it does not involve the disc space, and this peculiar behavior of this one distinguishes from the pyogenic osteomyelitis. There are two reasons actually that the disc space is not being involved, early versus late. In many late infections also, when the abscess formation is not there, there is less chances that disc will be involved. Why? Because, yes, anyone who want to comment on this one? Why there is a less chances of disc involvement in this one? Disc is involved, but late. Early involvement of disc is less. Yes, please. Yes. Vascular supply, excellent. Disc is avascular area. That's why there are chances that less supply to that. Okay. As compared to, that's why early infection of the tuberculosis, that's why it's misdiagnosed as that we can say it's related to the neoplastic. Look at here, this is kind of early infection, and the disc is somewhat is intact, and there is a just little bit, you can say, the thickening of anterior longitudinal ligament over there, and with posterior elements is not involved yet, but the body is involved and enhanced. So this early infection, osteomyelitis, or you can say not osteomyelitis, sorry, spinal tuberculosis, is confused with the lot of other differential diagnoses like neoplastic lesions. So, but when you see the chronic infection, as you know that when the chronic infection is there, the symptoms are more pronounced, and they provoke, and the clinical symptoms, as well as patient has some, you can say, the deformity over there. So both of the symptoms will provoke as compared to this one. Okay. And when we talk about this one, we will later on see the symptoms of this one. I will not go into detail, just a brief overview that. So chronic infection always comes with the most of the time some kind of deformity, either you can say the gibbous formation, whatever, that results in the kyphosis, moderate to severe kyphosis will be there, or they, you can say, they can some kind of a deficit with that one. So there are two main things with the chronic infection. One is the deformity and second is the deficit. Most likely the chronic infection came with the deformity and deficit. Mean deformity, we know that in the non-operative patient is 15 degree, but in 5% of patient, the deformity is up to 60 degree. That is significant, and patient can have the surgical intervention. And then this is because of severe kyphosis. We know that when the single level is there, the kyphosis is less likely. When two level is there, then the chances of more kyphosis. When the multiple levels are involved, and the anterior vertebral body height is more decreased less than 50% chances of kyphosis. One thing is that when the anterovertebral height is not decreased less than 50%, but the second thing is that when the posterior elements are involved, associated with the anterior column and the middle column, again there are chances of kyphosis, severe kyphosis. So these are, somehow overview of early and late infection. There are two things we have to differentiate in between these two, in adults and children. Actually, in adults, when the kyphosis is there, it becomes static after healing, or you can say conservative healing, and then after the surgery we are doing, you can say the decompression and fixation. There is a kyphosis will be static when the healing is there. But in children, it progresses up to 40% of the cases. This is the rough idea because of the growth of that one. Epiphyseal end plates are there that grow in children. That's why the kyphosis can occur after healing as well. Till that when the end plates stop to grow. So when there is a classification of progression that is called the Rajesh-Keran classification, it says that there are three types. Type 1, for increased deformity and until there is a stoppage of growth, that should be treated with surgery. Decreasing progression with growth, that the progression is decreased but growth has also decreased. Minimal change during either active and healed phases. So this is the type of progression is there that is divided into three types according to Rajasthan classification. But when we say according to involvement of these infection, that there are four types of involvement. That one is the anterior involvement, second is the posterior involvement, then the central involvement, that is called the body of, you can say, the vertebral body's involvement. And third one is the joint involvement. We have discussed in detail the different types of joint in the spine, from cervical to thoracolumbar joints. So the joints are delayed involvement of joint is there. When an infection is spread from anterior to posterior elements all, then there's a last chance that joints can involve and that can decrease the mobility. That joint involvement, actually, when the joints are become involved, it means the patient can have severe type of the pain because they have the restriction movement, and when the movement will be there, the patient feel the pain due to involvement of the joints. Cartilage has been damaged and inflamed. That's why the patient can have the severe kind of a pain in the later on and late stage as well. Out of these all four, the anterior involvement is more common. We have discussed just now that because of the richly supplies, you can say the subchondral paradiscal bone due to the arterial arcade. Then infection is traced through the help of anterolongitudinal ligament and then lead to the anterior vertebral bodies. Anterior and the posterior, the anterior is supplied most likely because of the spread is because of the arterial arcade. But when we say the central involvement because of the venous plexus, that's called the Batson, is typically results in infection that arise from the central of the body, and that is late as compared to the early one. When the older individuals are there, this is more common in older one. When the young and children are there, this is less common of central involvement because of the osteoporotic spine. When the older is there are degenerative spine, and the osteoporotic spine is there, the bone became very spongy vertebral body. So there is a chances that they get the early or the same duration of involvement that of anterior one in the older age group. But the younger age group and child, they get late involvement in the central involvement as the body is very strong and hard. Posterior involvement, again, this is because of the venous heterogeneous spread, because of the posterior venous plexus And again, two involvements are very important and typical, and you can say that's the anterior one and the posterior one. And these two involvements decide later on the surgical approach and management option. When the posterior involvement is more, we can switch to the posterior one because it endangers the posterior elements. When the anterior involvement is more, then we can see the anterior approach is more superior as compared to the posterior. But this is a rough concept nowadays in TB spine, that when the anterior is involved, you have to go anteriorly. When the posterior is involved, you have to go posteriorly. This is somehow a rough concept. Though the anterior is involved, a lot of neurosurgeons, they are going posteriorly. We will see that what posterior approaches are there which can encounter the anterior pathology as well. This is synovial joint joint involvement, that is relatively buttrate, but this involvement of facet joints. But this synovial joints and involvement is more common when we talk about the cervical spine. You have seen the cervical spine tuberculosis. They can cause the atlantoaxial subluxation, or there are atlanto-occipital subluxation or dislocation when the TB spine is there, because that is related to the joints. But when we talk about the thoracic and lumbar, this is rare and late involvement. When they become severe and are not treated properly, then joint involvement could be there. You can say that it is the second stage of the cold abscess in late spinal tuberculosis. Large, whatever the involvement of the spine is there, and the most likely the paraspinal, there could be the collection of abscess without severe pain or frank pus or prominent inflammatory signs and symptoms. Could be the huge abscess, but patient don't have such kind of a symptom, that we call it cold abscess. When we have gotten that the history and the examination that patient has the some features of spinal tuberculosis, so what investigations could be there? There are two types of investigation. We divide into two. That one is the radiological investigations, and second is the labs investigations or laboratory investigation, blood investigations are there. Both have a lot of importance, and not equal importance, but lot of importance over there. As we are surgeons, who from our point of view, the radiological investigation is more important as compared to the laboratory investigations, because most likely on the basis of radiology, we decide the involvement of anterior, any kind of compartment involvement. And on the basis of radiology, actually, you can see the all stability, instability, classification of surgeries, they are depend on the radiological classification, radiological investigation. So that's why the radiological investigations are important in our point of view. But we cannot say that the laboratory investigations are not important. Okay, but we have to be well aware of all the cultural injections. When we talk about the plain X-ray, it has been replaced by the CT scan nowadays, because the CT scan has good kind of detailed anatomical landmarks can be seen, early versus late changes can be seen on the CT scan, but we cannot say that plain X-ray has no role. Plain X-ray actually has the role, but is the investigation which can tell us even the early findings. You can say the 4 to 6 weeks. Suppose the patient has the tuberculosis right now, so plain X-ray can diagnose that one. The changes can appear to the plain X-ray after 4 to 6 weeks of duration of this age. It means after 1 month or after 1.5 months. And that the changes that will be there, that is the early end plate erosion could be there. You can say the scopoling would be there, but it is when the significant cupping or scopoling you can see when there significant involvement over there. It means the we can say the infection has been turned into the chronic infection, and when you see the changes in the plain X-ray end plates. CT scan, we talk, it has the good importance, a lot of importance over the X-ray, because when we say there are 4 patterns of CT scan changes in the tuberculous spine, we can step by step these all changes could be there. And second, these all changes can be seen on the CT scan, but X-ray cannot show these all changes. First thing. Second, we can assess the kyphosis properly on CT scan. Third, we can see the bone involvement, that how much bone is strong, or you can say it is not springy, while we are doing for the, you can say, the screw or the fixation and the decompression and fixation and instrumentation. So that point of view, CT scan has good. So 4, you can say the patterns are there. That is the fragmentary pattern. That is most common because when the CT scan and when the tuberculosis spine is involvement over their entry and plate, and when they become more fragile and more involved, a lot of fragments could be there, that multiple fragments, and that multiple fragments can migrate from different regions, superiorly, inferiorly. We have seen multiple times there the superior end plate has been broken down and fractures, and inferior plate has been fractured down. So, or the posterior end plate has been fractured down, and there's a retropulsion over there. And second is the osteophytic. When the multiple fragments are not there, but it's somehow to the, you can say only the osteophytic presentation over there. Just it's the anterior most likely. We'll see the longitudinal ligament has been thickened down and shows some kind of a presentation of osteolytic. And second is the subperiosteal. Subperiosteal, when we see just below over there will be thickening like of OPLL. You can see the radiographic presentation, and sclerotic when the wall of lesion with reactive bone formation represent, that patient has the good immunity. And there will be the actually it's like a rongel type of, you can say, the bone over there that can show the sclerotic type of you can say the lesions. So these are different patterns that we can be appreciated on the CT scan, but not plain X-ray. These are some patterns over there. Look at here. That is the fragmentary pattern. The multiple fragments are there, anterior and posterior, that has been one vertebral body, superior and inferior, both has been broken down in multiple fragments, and they can cause there. So look at here, this picture that is only involved into the inferior end plates over there. And again, this is fragmentary type of this one. And here is the sclerotic lesion over there. Okay. So these are the different changes that can be related to the CT scan, and CT scan can appreciate very well that what the level of damage over there. So after all, though the CT scan has a good, you can say, the role in tuberculosis spine, again, when we talk about the radiology, MRI has the gold standard. MRI is the gold standard with contrast, not plain. So MRI contrast is the gold standard. We have to go through the MRI contrast. That is the most common sequence, the standard sequence T1, T2, and see the contrast gadolinium enhancement will be there. So it shows the T1 hypointense. We know hypointense all involvement of the TB spine. It's the anterior longitudinal ligament that will be hypointense. If the body is involved, that will be hypotense. Whatever involvement of tuberculosis over there will be the hypointense signals on the T1 weighted. Whatever involvement of the tuberculosis spine in the compartment of the spine, there will be the hyperintense signals and the T2 weighted images. And we will see the contrast. Contrast will be the enhancement of contrast. When we talk about the ligaments, when it is placed just below the ligaments, there will be the whole ligamentous enhancement. When there is a just beneath to the environment, there will be the subligamentous enhancement. When the disc is involved, the disc will be enhanced. When the dura is involved, dura enhanced. So whatever the involvement will be there will be the enhancement of, you can say, of that pathology on the contrast. So that is second thing is that uh, sometimes when in the patients there is a disc is preserved. We know very well that disc is preserved and the body is only involved. That we call, very well that floating sign, disc sign will be there. Superior vertebral body, inferior vertebral body, both are involved, or single vertebral body is involved and the disc is spared, then we call that the floating disc sign is there. That is, you can say, not a pathognomic, it is some feature of one of the feature of tuberculosis spine. We have discussed that sometimes even though the cold abscess or not, but paraspinal collections are typically more well supplied with flucenter and well-defined non-margins. Same picture will of abscess, any abscess that is there, that central will be less enhanced and surrounding capsule-like enhancement will be there, that we call is the ring type enhancement. These are different pattern of enhancement. Look at here in this picture that this is the early infection and this is little bit involvement is more as compared to this one is some kind of a same picture. Look at here, this one, that third one, that is the anterior longitudinal ligament has been involved. Superior inferior vertebral body is involved. Posteriorly, it has been involved, the posterior longitudinal ligament, and there is a collection anterior to the longitudinal ligament over there. Anterior vertebral bodies, that is called the abscess has been formed. So this is all enhancement pattern over there that has been shown, and the vertebral disc is being involved now from the posterior side. So this is different types of involvement, or you can say the pattern of MRI contrast over there. When we talk about the different diagnostic the process over there, so apart from you can say uh, the MRI, that is the gold standard investigation. Anyone who can tell that what is other gold standard investigations for TB spine? That is not, that is, you can say, the lab investigation. Which lab investigations is gold standard? Yes, please.
Sir, gene expert?
No.
Quantiferon TB gold test.
No. It has been written here, interferon Y, that is less specific. Yes. Oh, what happened? Yes. Anyone? Yes, or CRP? Very no, no, no. What is IGRA, Dr. Kingsley?
Means interferon gamma release assay.
Oh, no, no. The histopathology and culture is the gold standard, the lab investigation. When we talk about the radiology, MRI is gold standard. Apart from all, they are not, some are less specific, some are less sensitive. They are not gold standard. When we talk, we have to see the culture and then histopathology. That is the biological, you can see the test, that is the gold standard of, you can see the lab investigation. So these are different kind of investigations. I have put it down it, but there's no need to memorize these all, but we have to be well aware of this one. When we talk about MRI, it has been sensitivity is excellent, 100%, 80% is specific. CT scan sensitive 100%, but not specific as much, specific is less. So nuclear scan, that is not too much specific, not too much that one, because it cannot differentiate the malignancy from other one. ESR, though there is more, there are 2 to 3 times ESR raised as compared to the normal one, but we cannot rely on the ESR and CRP, Montauk and interferon bias. These are the different tests over there. Okay, so we have to be well aware of only the MRI and then the histopathology. They are different kind of investigations. No need to go through all these kind of investigation. The CT scan and the MRI, and then later on the culture and histopathology. So now we have come to know that it has been diagnosed that this is the tuberculosis spine. So what could be the management there? So there are 2 types of management. One is the medical management that we call conservative. It has been written here that what medical management could be there. That is the anti-tuberculosis treatment. Anti-tuberculosis treatment, the standard is 9 months, but some says this, that you can say up to the 12 month, and Spine says that, Artho says that you can go up to the 18 months over there. But the standard treatment, that is the 9 months there. When there is no any multi-drug resistant tuberculosis, that 9 months is sufficient. We divide this ATT into 2 phases. One is the initial phase, that is 2 months, and then continuation phase, that is 7 months. Initial phase, there is 4 drugs, that is the isoniazid, rifampicin, pyrazinamide, ethambutol, or you can skip the ethambutol and streptomycin. Continuation phase, that is 7 months only, the isoniazid and rifampicin. One thing that I left here, I forgot it to put here. When the initial phase is there, we also give to the, we have to also give the, you can say, some kind of anticoagulants. Like you can say this S-card, we have to give S-card in initial phase. Anyone who has the idea why we are giving the S-card? Anyone who are giving the S-card in their practice with the patients? DVT, no. Anyone who are giving that one? Anyone who follows this practice and protocol and initial phase, either it is a spinal TB and either it is a, you can say the brain tuberculomas are there and spinal TBs are there. To improve blood supply. More it is the guideline from the infectious diseases, more practice common in the brain tuberculomas and TBs, but spinal tuberculosis, it is also can be given in that one. Okay, so S-card, because that to prevent from the ischemic changes, when there is a involvement at the cord level, because why patient comes with the deficit in tuberculosis spine, and because it turns into the osteomyelitis and causes the epidural abscess. You have seen and in the pathophysiology of osteomyelitis, TV osteomyelitis and epidural abscess, that the patient have the deficit because of the ischemia, cord ischemic changes. So to prevent that ischemic changes, you have to add that you can say the SCARD or anticoagulant in initial phase for 2 months, because the deficit is because of the changes, ischemic changes. Same deficit can be there when the tuberculomas in the CNS, because they can cause the small vessel ischemia, not the large vessel ischemia. They can cause a small vessel ischemia in the brain, the tuberculomas. To prevent that small vessel ischemia in the brain, we have to add the SCARD in initial phase. So this is the guideline. You can say ultimately to improve that blood flow. Antibiotics plus minus you can add, and steroids. Immobilization is very important. Strict bed rest or immobilization. Cervical area is there, cervical collar. If thoracolumbar area is there, then you have to apply the thoracolumbar brace on that. So when we talk about the conservative management, what are the indication of conservative management is very important. Then one thing that when there is a no neurological deficit is there, we can treat it as the conservative management or medical management. When there is a single vertebral body or disc space is involved, we can do a conservative management. When the patient is giving the response to the medical therapy, we can give the conservative management. When you can say the culture has been the diagnosis is definitive and we have the cultural sensitivity, we can do the conservative management over there. So these are the indication of conservative management. But when out of all them, when there is a refractory to the medical therapy, when there is a multi-drug resistant, when there is a neurological deficit over there, when there is a significant kyphosis is there and the gibbous formation was there, when the more than one vertebral body is involved and disc space is involved, when there is no any culture and sensitivity, antibiotics and medicines are not working, patient having the neurological deficit, then there is an indication of surgery. That is called the surgical indication is there. So you can say that we can do the surgical indication. But again, we have some instability classification that can tell us that is instability is definitive or not, and like a Tillich score is there. So we have to see that instability. There are different classifications. So when we talk about the surgery, these are the surgical indication. When we talk about the consultations, there is some classification that one classification that can tell us the anterior and the posterior approach, what approach is appropriate. That is called the GATA classification. I think you people know very well that what could be the GATA classification. There are three types, and type 1 is divided into 1 and B. When there is single vertebral body is involved, or you can say the single disc space is involved, and no collapse, no abscess there, that is type 1. Type 1 is most likely there's no need for the surgical treatment, that is conservative medical treatment will be there. Type 2, when the vertebral body collapse is there, start to abscess formation and the kyphosis there, and then the patient can have the neurological deficit, that is called type 2, and it is either it's a one vertebral body or just two vertebral body. The type 2 more likely when there is a more than 50% of single vertebral body is involved, or one vertebral body is involved, and all other features are there, that will be the type 2. So as in this one, the most likely involvement is anterior. It says there anterior you have to debride and then fuse with the help of anterior approach. When there is a significant kyphosis there, severe vertebral body collapse is there, or you can say the more than one vertebral body is involved, patient has the abscess formation and the neurological deficit is there, then again you have to do the global reconstruction, that is anterior and posterior. Anterior debridement and the corpectomy you can do if the complete vertebral body has been collapsed. Then posterior you have to do for the 3-column fixation over there before putting anteriorly the graft in between these two vertebral body. Previously we have seen the anterior, you can say approaches. This is the score that is called an instability score. That shows that instability is there and there is indication of surgery. Instability means there is indication of surgery. You have to intervene that one. So there are different parameters over there. There are 5 parameters and variables, you can say. That variables are 5 and the result total is 9 score. That will be counted in a sense. Each variable has different score. The young age is a good group because the age is less than 15 years, the score will be 1. Cervicothoracic or thoracolumbar junction. Any junctional area is important, that will be score 1. When there is a low any junctional area, score will be 0. Suppose that a lesion is at the level of C7 and T1, their score is 1. But when there is a at the level of T4 and T5, the score will be 0. Same that up when there is a pathology at the level of T12 and L1, that will be score 1. Then there is a level just below to that junctional area, the score will be 0. So the kyphotic deformity is important. The kypho is significant when it is more than 30%, sorry. Then again, the score will be 2 in this one, the kyphosis. We have to see the vertebral body length and segmental ratio collapse. When there is more than 0.5, we will give the score 2. Spine at risk sign. Spine at risk sign means the patient can have the deficit. The patient can have the symptoms of any kind of myelopathy. The patient can have the symptoms of cauda equina. These are the symptoms that is called the risk signs, that will be the score 3. So out of, when we combine this one sum up, there will be the 9 score. The stable score will be 0 to 1. And the potential score is 1, that we call it the 1 score. Instability will be counted when the score will be 2. And the definitive instability will be counted when the score will be more than 3 or above 3. So when the 3 are above, it means definitive surgery will be there. When the instability over there is score 2, that is plus minus gray zone area, that you have to go doing conservative or surgical approach. When the score is 1, that is that you can do up to 1 score, the conservative management. So this is the instability score that is nowadays being followed in the tuberculosis spine and the GATA classification, and second is the Kessler-Jan classification over there. So look at here. Yes. Look at here, it has been conservatively managed. This patient, when the single body, the deficit was not there, but there are huge, you can say, the involvement of abscess are there. The disc space is involved, but single disc space is involved. Patient has an intact neurology. It has been followed from 0 month to 9 months. And as per recommendation, the radiology has been done. After 9 months, patient has almost all the culprit is not there. That is, the anterior longitudinal ligament is normal. There is no any first disc space is about to be normal. So this is one example of, you can say, that conservative management of TB spine. But we have to follow 2 things. One is the clinical symptoms, and second thing is that of neurological deficit, and third one is the radiology. When though the neurological deficit is late improved, when the patient can be the neurological deficit, but symptoms and radiology are important. When the symptoms are not being subsided, we have to see that there is a resistant or non-compliance, because sometimes patients are not getting the treatment. Yeah, 2 factors. And second thing, the compliance is good and there's no any resistance, then we have to see the MRI. The MRI is improving or not, patient is improving or not radiologically. Again, from it is recommendation, when there is symptoms are plus minus and radiological improvement is not being improved, it is getting worse, from 3 to 6 months. Again, there is some protocols are there. Some surgeons say that there's indication of surgery when there's a more than one involvement are being there, significant, and the radiology is getting worse. So surgical management indication, we have discussed that spinal instability, there is a chances of their instability score is recommended, that is 3. Kyphotic deformities are there. Persistent or worsening neurological deficit patient have more than 2 levels or 3 levels are involved. Drainage of sepsis and tissue sampling. Failed medical management patient has, that is called, that are different indications there. It is now there are two things, that what is the anterior versus posterior approach, when we have to do anterior approach and when we have to do posterior approach. Because in tuberculosis spine, most likely the anterior elements are more involved as compared to the posterior one. There are some advantage of anterior approach and there are different advantage of posterior approach. In stability, when we talk about the stability and fixation and decompression, one thing that is involved when there is a structural problem. Suppose that what's mean by structural problem, when we talk about trauma, when we talk about tumor, when we talk about infection involving the spine, the main thing is that this says that there is a sparing of normal structures. Those surgeries which are sparing the normal structures, they are not taking off the normal structures that are good. The anterior approach has, in this sense, the good advantage over there, that the normal structures are spared. In this one, they are not being taken off. Like when there is an anterior body is only involved, the posterior elements are intact, because we are addressing only the anterior culprit area, that is the anterolongitudinal ligament or body, but posterior elements are intact, we are not damaging that one. But we talk about the posterior approach, because the posterior approach, to somehow we are compromising the posterior elements, we are damaging that normal structures when they are not involved. When they are only the anterior involvement is there and we are doing posterior fixation, it means some of the posterior structures are being compromised. So this is one advantage. Second, that the posterior has the 3 column. When we talk about the posterior involvement fixation, that is the 3 column fixation is there. But when we talk about the anterior, only 1 column fixation is there, that the main disadvantage of the anterior column. And second thing is that when the severe kyphotic deformity is there, when there is a severe deformity more than, you can say, the 1 level or 2 level is there, very difficult that anteriorly it can be corrected, then we have to definitely go to the posterior. Whether a single body involved is there, the posterior element are good enough intact, then we can do only the anterior approach with the fusion and fixation technique. But when there is a significant kyphosis, when there is a significant, you can say, the deformity is there, when the more than 1 or 2 levels are involved, then we have 2 options, that we have to go for the global reconstruction, that is anterior and posterior. And second thing is that is says only do the posterior approach. When we are doing the posterior approach, so how can we address that that the pathology that is anterior to the cord? How we can decompress the cord? Anyone who has the idea? Yes? Anyone who has the idea? Suppose that I am in favor of posterior approach. Yes, I am in favor of posterior approach. And anyone who is in the favor of posterior approach, how we can decompress the, you can say, the posterior, the anterior part of that one. Yes, please. These are different one. These are different surgeries you have seen. Laminectomy, With the help of laminectomy, can you do the anterior decompression? With the help of laminectomy, can you do anterior decompression? Yes, anyone? The single body involvement you have seen, look at here, the single body involved, and there's the abscess over there. They went through the only anterior approach. They did the corpectomy, and then there is a graft over there, and then there is a fixation that is called one column fixation over there. Look at here, this is the posterior fixation and the posterior decompression over there, as compared to that one, that the posterior multi-level segment decompression and fixation over there. Again, there is a one another example. What approaches has been done here? Is the anterior approach or posterior approach? Is the anterior approach or posterior approach?
Posterior approach.
Posterior approach. How posterior approach? Because posteriorly we have 3 column fixation. Yes?
Yes.
Yes. No, it's a global reconstruction, that is the anterior approach and posterior approach. Anterior approach, the graft carpectomy has been done. After carpectomy, a graft has been placed over there, a cage has been placed over there, then long segment posterior fixation over there. So this is the anterior and the posterior approach. Why the anterior and posterior approach? They say that posterior approach has advantages over the anterior approach. Why? Because there are 2 things. One thing is that the stability is good. What is the goal of surgery is very important in tuberculosis spine, because when the pus formation is there, more likely if it is diagnosed that is a tuberculosis spine, the more chances is that it give the response to ATT and antibiotics. The goal of surgery is stability of the spine, and stability is good enough when we are going the 3 column fixation fixation over there. And second thing is that we can do decompression anterior decompression with the help of posteriorly. Wow, how? There are 2 school of thoughts, they says, and previously we have discussed that one when we did the posterior and posterior lateral approach in the thoracic spine, that how we can approach anterior to the vertebral body, posterior to the vertebral body, and you can say the anterior part of the spinal cord. Because when we are doing the posterior midline approach, we have the option of transpedicular approach. We can do transpendicularly, we can bilateral transpedicular approach, we can do with the help of anterior decompression, because the main thing is the cord decompression. Second thing is that you can go, you can say the extra cavity approach or the costotransectomy over there is there. That is also considered. Some surgeons, they say that it's the part of, you can say, the posterior approach. So that's why posteriorly has now a change. The guidelines have been bit changed. But if you need the cord decompression, we can do transpedicularly. We can do with the help of costotransectomy. We can do with the help of, you can say, the extra cavity approach. Even we can do with the help of posterior midline. Posterior midline, the transpedicular will be good. And that laminectomy cannot only decompress the cord. If you are doing that one, you have to do the ligamentotaxis. Okay, so this is about the spinal tuberculosis. Yes, Dr. Isra, you are right. Stability is the main aim of that one, main goal. So when stability is there, so we have to choose that approach which give good stability. as compared to, you can say, because our target is stability when we are doing the surgery, not to diagnose, not the diagnosis, not the culture, not to address the only, you can say, the abscess and the debridement. Our only target when we are doing the surgery, and the best target is most common one is the stability. So stability, what approach is giving good stability? Do that one. But there is a controversy, and up to the surgeons that what they are doing. Yes, Dr. Kamal, I have finished. So in this way,
Okay, I raised my hand, but you were in the thick of the discussion. I did not want to interrupt, so I just lowered the hand. Thank you so much. Tuberculous spine it's not a topic that even I was looking forward to. It is dry and it is difficult, and thank you so much for making it as easy as you could. I'm going to share the link to the recording in a while. Thank you so much, everyone. If there's any question, any feedback, we are open to it.
there is a long discussion over there. I think Dr. I included the gene expert in, you can say, the investigation, but I'll not recommend that it is the gold standard. I included this one. Anyone who has the question and want have the discussion, need discussion regarding this topic and different parameters and aspects, put that question and query and any kind of comment on group. We can do a healthy discussion over there, inshallah. In according to in relation of this topic is spinal tuberculosis.
Okay, I think that's it from your side and from my side as well. Also, a little announcement, everyone, we will not be having a session tomorrow. Unfortunately, I had an unforeseen appointment at the same time, so we would have to skip tomorrow, inshallah. I will announce this on the group, and let's see when we can start. On the Wednesday, we will probably do the spinal tumors on Wednesday. Let's see. Okay. Thank you so much, everyone. This is a wrap for today's session. Thank you, Dr. Itzas, for taking out your time and joining us. That's a wrap.